Hi everyone, welcome to your final session where we're going to look at the principles of trauma-informed practice, and we're also going to look at things like vicarious and secondary trauma. So we're going to start with the idea of the concept of the 4 R's. So they are hopefully what this course has been able to give you, which is the realization that trauma exists, what kind of trauma we're talking about, how trauma can manifest itself, and then how we recognize trauma. What do we see in people? What might their symptoms look like? What kind of behaviors might they have? How might they connect or disconnect with the world around them? And then when we see those things, or we ask about those things, how do we then respond to that? Because we're not trauma therapists, but we can do a lot to help people understand themselves, recognize their triggers, make the links between their past and their present. And we can also actively resist and avoid re-traumatizing people. So we're going to talk a little bit more about that in this section today. So when we're thinking about what a trauma-informed approach would look like, it's that we are realizing and recognizing, like I've just said, but we also need to understand what recovery looks like and what a potential path to recovery might mean for us and where we fit in with that recovery path. So that might mean thinking about what's in our policies, what's our staff wellbeing policy, for example. What procedures might there be around a staff member who maybe is suffering from vicarious trauma? And what might we do to make a reasonable adjustment to their practice? For example, taking staff example, because as we said at the beginning, this is about everybody. This is not just about the people who are using the services. It's about those people who provide the services as well. And this has come from the trauma-informed health and care approach for responding to child sexual abuse and exploitation. So one type of work that we might be undertaking when we're working with traumatized people. So Research in Practice have done a really useful document called The Features of Trauma-Informed Approaches and Their Application to Working with Children, Young People and Parents. And you can see that there are lots of themes that have come up that we've been talking about all day. So safety, survival, partnerships with people, what pathways there might be to specialist treatment, how we recognise trauma, how we avoid re-traumatising. What we haven't talked about much is the cultural, the historical and the gender context. So how do we think about that young person or parent's culture, and how those kind of aspects around identity, so maybe their gender or their race or whether they have a disability, all of those things will impact on their trauma or might be the cause of their trauma. So how do we understand that, and how do we make sure that people feel recognised and understood in their specific context? And that's of course how and why we build trust and transparency. That's how we do those things. So we do them through collaborating with people genuinely, from having a mutual approach to the work and being empowering, not doing things for people, but helping them believe that they have the capacity to do it for themselves. So kind of a breakdown of some of these things, and I won't go through all of them, but things like survivor partnerships. Can we enable, so maybe, parents who've had their children removed, could they have an opportunity to meet other parents who've been through similar processes? Because what people say is it really helps them when they meet other people who've experienced that, and it makes them feel less alone. Could we, for example, help establish where people could go and get some EMDR, for example, the really good eye movement technique that has really good results around trauma? Can we have a look at who offers that in our locality, and create like a little handout for people where they might want to go to find somebody who might be able to offer them some EMDR? It might be that we are looking at trustworthy and transparency. So we're really clear about what it is we're going to do and why we're going to do it, what the rationale is behind it or what the theory base is behind it. And then when we say we'll do it, we do it, because people don't take kindly to being let down if they've had a history of being let down. So there's lots more detail in this document, but I'm just showing it to you because I think it's a really useful one to kind of do as a bit of an audit against how you work. So let's think about re-traumatization then. So we mentioned it earlier that is something that's a reminder, consciously or unconsciously, of a past traumatic event that then gets re-experienced in the here and now. So the triggers for those could be anything. It could be something that you see, hear, smell. Think about all your senses and how the brain takes in information through the senses, and then it makes sense of that through deciding if it is something that's going to be replicative of trauma that you've previously experienced. And then what the brain will do is, ask the body to go into the state that it needs to go into to defend itself. So if somebody was very much disempowered and part of their trauma was around having no power, then if they have no power with us in the provision of the service that we offer, then that's going to be a trigger, and that's going to send their brain and body back to that state. With children, they often have no idea that they've gone into those states or why. They just feel these really intense emotions, but they won't be able to make sense of it, which you can imagine can be very frightening. So from the School of Social Work, they're talking about what the impact is of re-traumatization. So that's about loss of trust. People's levels of self-injury increase when they're re-traumatized. They're less willing to engage with any treatments that are offered. They're more likely to have intrusive memories, nightmares and flashbacks. They may then, of course, become delusional depending on the severity of the trauma, and it can increase other things that are already happening. So it can escalate depression, or it can, create PTSD symptoms again. And if people have experienced this before, then when they get re-traumatized, then that's going to increase the intensity of that. So what do we do then if people are re-traumatized? How do we address this? So we have to be really sensitive to individual need. We have to attend to the reactions behaviourally and emotionally when we see them and work to decrease them together. Maybe we can do coping plans with people in advance, so before they happen. Maybe we can talk to people about what coping strategies they've already got and what already works for them, and then how we can implement those and use those when we're working together. Maybe we can try out some new things and see what works and what doesn't. Mostly, we really need to think about not shaming people for their trauma-related behaviour, and to, if it's a behaviour that's really problematic, for example, talk about the behaviour and not the person, and to be really consistent with that, so that we avoid shaming people and we recognise that this isn't them, this isn't their character trait, this is their brain and their body reacting to fear. In the Eileen Monroe research, when they were asking children about what do they want from services, they basically described trauma-informed practice. So spend time with us, give us your attention, don't get us to repeat our story over and over again, so don't re-traumatize us, keep us at the centre of your decisions, be honest and explain it in a way we understand it. Let us make some decisions about our own life, and don't make assumptions about how we think or feel. So again, take an individual response. So they very clearly were saying what to do, which very much backs up the theory that I'm sharing with you today. So we have to remember that, we're not mental health services, and we're not a substitute for those services. And many people will need specialist trauma care, but we can make a difference to how well and able they are to access the services that we work in, and that if we assume that everyone might have experienced trauma, then we can make sure that we work in a trauma-informed approach with everybody, and that changes and challenges are avoidable sometimes, but not always. But when those things do happen, that people will be much less resilient to managing those stresses compared to people who haven't got trauma. Other things we can do are thinking about principles of theories like connect before correct. So if we're trying to engage their kind of logical part of their brain, we need to connect with them emotionally first, because that will make a huge difference if we have that connection with them already. We need to be aware of what ACEs they might have experienced. We need to recognise that the earlier we get in there and the more we can talk about and educate about trauma, the more useful it will be. That we have compassion and a really good understanding of where the behaviours have come from, and it's not necessarily a choice that people behave in these ways. It's reacting to fear. If we use things like motivation interviewing, strengths-based practice, we focus on building resilience and emotional literacy and awareness. These are really useful tools that we can use in our practice. That we remain empathic and we remain self-regulated, that we validate people's experiences and we recognise what they've gone through, and that we teach people about trauma and the brain. Coming back to the Youth Justice Board paper, they talk very clearly about the challenges working with traumatised children and young people, and that it can be really difficult for staff because some young people can cause, within us a lot of frustration or despair and anger, and that's not their fault. That's how their behaviour is resonating with us, and often it's because it's triggered by something else that we've experienced as well. And so we need to be able to really reflect on our own relationships with trauma, and we need to be able to recognise which children and young people we find particularly difficult and why we find them particularly difficult. And therefore we need a really good, safe environment like supervision and peer support to be able to say these things. If we don't like a client, that we're able to say, I just don't like them, and I need to understand what it is about them that's creating this response in me, so that I can move away from that and I can treat them with compassion and kindness, because these are all really normal emotions, and if we just pretend we don't have them, it doesn't help. We need to face them, recognize them, understand that they're normal, and find a way to get past that so that we can have a really good understanding of ourselves and our connected relationship with that person. On that same theme then, when we don't have that space and we don't have that trust to be able to talk about these things, it can make us much more vulnerable to things like vicarious trauma and burnout and compassion fatigue, just to name a few. So if we're thinking about vicarious and secondary trauma, it's understanding that this is something that follows from exposure to other people's trauma. So we can then take on their traumatic symptoms, and we can have similar sort of PTSD symptoms. We can have similar feelings about the world, for example, to people that we support, because of the way our brains and our bodies are connected. So this could be from a single event, or it could be from repeated events and exposure to that. Dr. Rachel Remen says that the expectation that we can be immersed in suffering and loss daily and not be touched by it is as unrealistic as expecting to walk through water without getting wet. It's part of the course of working with traumatized people. And so we need to be able to be supported and recognise that all of us are at risk of traumatic stress if we work with traumatized children and adults. How we might recognise that are things like our feelings. Maybe we feel anger, maybe we feel shame, where we feel rage or sadness. Maybe we notice ourselves becoming, a bit enmeshed and overly involved with this particular child or family. Maybe we start to think about them at times when we're not at work. Maybe we feel guilty when we're having a nice meal with our family because we know that they don't have that opportunity. Maybe we find difficulty maintaining boundaries and give one of the young people our phone number, for example, because we're so worried about what's going to happen to them tonight. Maybe we've noticed that we don't have much hope left anymore, and we start to predict what people are going to tell us, or believe that actually nothing is going to make a difference to this person. We sort of lose hope and become pessimistic. Or maybe we detach ourselves and distance ourselves by not really listening properly to people anymore, and find ourselves kind of being constantly busy, so we can't have that reflective time because we're too busy to be reflective. Because if we are reflective, then we have to face what it is, that we're witnessing, and that's too painful on top of all the other things that we've witnessed. So it's things like that. It's similar things to the trauma that the people that we're supporting experience, but we experience in a professional capacity, even though we didn't have that trauma. What we've done is we've absorbed their trauma. Some other examples of how you might recognize these things: it might be that kind of avoidance, that inability to listen. It might be that you notice yourself being hypervigilant. Maybe you find that you've got diminished creativity, that you just can't come up with ideas like you used to because your brain has just been overloaded. Or maybe it's that you've kind of zoned out and you find yourself zoning out quite a lot and then you can't remember things. Maybe it's that you notice it in your body, that you're just really tired all the time and you've got pain. Or maybe it's that you feel that kind of persecution where you become a little bit self-absorbed and that you feel that people are kind of out to get you. Or maybe it's this, that you feel really hopeless and helpless and it's really hard to get out of bed in the morning. The Joyful Heart Foundation talk about, the guilt, that you can't enjoy things anymore, that you're frightened, you're waiting for the other shoe to drop, that you're jaded, that you're, struggling to access feelings. Maybe you're relying really heavily on coffee or alcohol after work. You notice that you're numbing yourself basically. Or maybe you minimize people's experiences and compare experiences and, struggle to understand why someone is reacting in the way that they are. Or maybe it's that kind of ability to have complex thinking has been reduced and that you've become much more kind of right and wrong. Maybe those are the things that you might notice. So ways that we can reduce these are by being really good at self-assessing and really having time to notice how we're feeling and what's happening to us. That maybe if we are feeling overwhelmed, that there's some opportunity to balance our caseload. So we have some clients that haven't experienced trauma. Maybe it's that we use our flexi time. Maybe we have buddying with another colleague so we can talk things over more. Maybe it's that we need to up our level of rest at home, that we need to eat well. Often when we're really busy, we don't eat properly. When we junk food, which is really bad for our well-being and our emotional health. Or maybe we need to do a bit more exercise. Any stress reduction activities are going to be useful, and that we can look at what are our strengths and vulnerabilities and kind of map that. Having said all of these things, when we are suffering from PTSD symptoms, this isn't a case of you didn't look after yourself well enough or that there's something wrong with you and you just need to get better at managing stress. There are times when you really do genuinely need to not go to work and have time off so that your body can recover and that you can recuperate properly. Sometimes pushing on and just trying to do stress reduction strategies isn't enough. So depending on what's happening and the severity of it, the earlier we catch ourselves in these positions, the better. But sometimes it does involve that we need to have time off, and that's something that we shouldn't feel guilty about or bad about, because it's just part of the work and what the work does to us. There's a good evidence base for how valuable cognitive sort of strategies can be. So using things like mindfulness, having meditation practices, having really good reflective practice and reflective peer supervision, having more group-based processes where you can share these things. We need to do both mind and body, and if we can support our kind of cognitive processes around these impacts, then that's only going to be helpful, really. So in summary then, I'm just going to quote from Knight here: listening to young people, carefully helping them recognise how past experiences influence their ways of relating to the world today, and offering a trustworthy relationship where they can try to build a safer life for themselves. It might be the most important service that we can offer. And that's not just to young people, that's to adults as well. But helping you recognise your past and how that links to your present within a trusted, safe relationship is incredibly important. So remember that change will happen slowly. We can get frustrated because people can seem to take a backward step, but that's just part of the process. People will revert back to old feelings and behaviours, but if we carry on being consistent, slowly over time, the new brain pathways will get built and they will overtake the old brain pathways. There'll be new ways of thinking and behaving, and that people will start to thrive and not just survive their experiences. So as a final reflection then, have a look at your organisation. How does that fit with a trauma-informed approach? Are there any things that are working really well? Are there any things that could be improved? And then take that to, what about you? How does it work with you? How do you work within a trauma-informed approach? And how do you do that for yourself? How do you look after yourself and make sure that you are giving yourself the best opportunity to stay well within very, very complex, difficult and stressful work? So we'll talk about that when you come back in. Thank you for listening, and I'll see you soon.